Okay, we might just get started because I am conscious that it is people's mornings, people's evenings. We're arranged a whole different time zones here. So thanks everyone for joining. It's really nice to see a lot of familiar names here, but also a couple of new people. Before I start, I want to acknowledge that I'm joining you today from traditional, unceded, and ancestral territories of diverse Indigenous peoples. And I feel that this acknowledgement is especially important because of the broader work that we all do and the conversations that we engage in across this speaker series, recognizing how experiences of trauma, the body, and movement are shaped by many intersecting factors. And this includes the ongoing impacts of colonial histories. So today I'm calling in from the lands of the Sinext, the Katunaha, and the Silex people in Nelson, British Columbia. But I also acknowledge the lands of the university on which our team works at Carleton University in Ottawa, and that's the lands of the Algonquin Anishinaabe Nation. So nice to see so many of you on the call. This speaker series today is hosted by Carleton University's Health and Equity, Wellness and Equity Research Group, and this is led by Dr. Francine Darrick. So our team run the series of speaking presenters because we want to bring people together who are doing similar work in this space. So our team run a lot of trauma and violence informed physical activity programs for equity owed communities across Canada. And the idea of these sessions is so that we can bring people together who are doing similar work so we can showcase and learn from each other. Now, importantly, we really want to thank the Public Health Agency of Canada, who have funded this work for the past 5 years, but is coming to an end in March of this year. I also want to point out that we have numerous publications and knowledge mobilization outputs as a result of this work, which we'll be sharing throughout the year, and we'll pull up our social media channels at the end of this presentation. Now, today we're really lucky to have Dr. Oscar Lederman, who's going to present some of his work from Australia for us. Oscar is a long-term colleague and friend of mine, so I know we're in for an absolute treat. The plan for today is we're going to have Oscar present for about 40 minutes. That will hopefully allow us to have about 5 minutes of question time. So I encourage you throughout the presentation to please pop your questions in the Q&A in the chat. And then at the end of that, we're going to have our usual optional breakout rooms for the last 10 minutes. So these breakout rooms, you'll be able to self-select which you feel is the most appropriate for you. We're going to have three separate groups. The first one being service providers, the second one being researchers, and then the final group is our community advisory board from our project. And now I also want to mention, you probably saw when you joined the call that this session is being recorded, but importantly, those breakout rooms where we're having more in-depth conversation, those breakout rooms will not be. Now, Oscar has told me he doesn't want me to read out his bio because he's going to introduce himself, but I'm just going to give you one quick little snippet. So Dr. Oscar Lederman is a senior lecturer at the University of Technology in Sydney and the mental health research lead within the Human Performance Research Centre. His research focuses on reducing health inequities through physical activity for people living with mental illness and culturally diverse communities. Now, I'm going to stop talking and I'm going to hand straight over to Oscar. Thanks so much.
Thanks so much, Grace. Can you hear me okay? Thank you. And thank you for the team for having me come and present at this series. It's a real honor to come and present here and speak to some of the work that's been happening here in Australia. I too would also first like to start by acknowledging that I'm currently speaking from the lands of the Gadigal people of the Eora Nation, who are the traditional custodians of the land in which I am here today. And I want to pay my respects to elders past and present and acknowledge that this is stolen land. Sovereignty was never ceded and it always was and always will be Aboriginal land. Also extend that respect and acknowledgement to any First Nations people joining on the call today from around the world. Importantly for this call, I would also like to acknowledge the voice and experiences of those who have a lived or living experience of mental illness. Not specifically that group, but also those that are family and carers of the people who live with mental health challenges. The work and the information that we gather through our research is very much centered on lived experience, and we couldn't be doing the work that we do without that voice. So we're absolutely always grateful for having the voice of lived experience included in our work. So today, I'm hoping to give you a bit of a snapshot about my research program. And to do that, I think it's important to understand who I am as a researcher. So I'll cover a little bit about my professional background and then cover what my research objectives are. I've tried to really distill it down into a very simple two aspects of my research objectives. I'm going to be using case study examples to kind of talk to the work that I'm doing, and I'm hoping some of that resonates with what's happening in Canada and from what's happening around the world of where other people are calling in. And I hope that some of the practices and learnings can be useful in supporting those programs as well. I'll also like to acknowledge those who I've worked with, and then obviously spend some time for a Q&A and discussion. So first of all, I started as a exercise physiologist, which I know is something that's quite different across different countries. In Australia, exercise physiologists are university qualified health professionals, so we're an allied health discipline, and we learn things surrounding medical science and physiology to try and understand the mechanisms and effectiveness and types of strategies that exercise can be used to treat chronic and complex health conditions. So often we work with chronic disease management in diabetes, cancer, cardiovascular health, aged care. The area that I chose to work in was in the mental health sector. And at the time, it was a pretty new space. There weren't many exercise physiologists in Australia working in this space, but I was interested in mental health because I had friends with lived experience who, I was kind of unsure of what mental health or psychosis was at the time, but experiencing that through my friends' challenges was something that got me interested in how can I use what I'm studying in exercise physiology to benefit this group. I also had a family member who worked in mental health care, so I was always really interested in that space. So I was lucky enough to get a clinical placement while as a student in mental health, which led me to my first job. Um, while I was working there, I commenced a PhD under the supervision of Simon Rosenbaum and Philip Ward. So bringing exercise physiology and psychiatric expertise together as supervisors was super useful for me. And through my journey as an exercise physiologist, I really became passionate about mental health care and became somewhat of a mental health advocate within the exercise space and became a mental health first aid instructor. So besides what I do in the clinic, I was out working in other settings, trying to teach the exercise physiology workforce about mental health and doing mental health first aid training. Because exercise and psychosis was a bit of a niche at that time, I got asked to speak at a few different conferences, which was great. And then I've taken on this role as a lecturer at the university, trying to integrate the clinical practice knowledge that I developed, as well as the research to improve the skills of the future workforce. But today, what I'm really going to be focusing on is the research component of what I've been doing of late. To understand the research, I think the way that I helped understand it for myself was to figure out who do I do research for. So the primary group is people living with mental illness. So if I'm talking about mental illness, generally we're referring to severe mental illnesses. So psychosis or schizophrenia, spectrum disorders, bipolar, major depressive disorder. However, also doing a lot of work, including with Grace, for populations commonly exposed to trauma. Working with cultural minority groups, there's obviously some intersections there. In Australia, we have an extremely diverse population and lots of migrant communities here, and there's often co-occurrences of trauma with these cultural minorities. So very much overlap there. More recently, I have been doing some work in spinal cord injury and looking at the equity of access to care for people with spinal cord injury. But to help understand my research agenda, I really wanted to figure out what brings these groups together. And I could really summarize it by experiences of health inequity. Mental health challenges are a common feature across these groups, and physical inactivity. So these three things are kind of helping me centralize what my research objectives are. I will just say, slightly independent from that, I'm starting to do a little bit of work looking at mental health experiences in athletes and retired athletes in particular, which is just sort of a bit of a side note, but I'm finding some interesting overlap with these as well. So, what does physical activity or inactivity as well got to do with health inequity? Well, we all have heard that health is a fundamental human right. But we also know that physical activity is intimately linked to good health. Okay, so everybody should have the access to equitable care, and this is identified through World Health Organization. But as we know, physical activity is linked to health, but not everybody has the same access. So if we're talking about equity of care, we're talking about giving people what they need in order to achieve a fair outcome. So that doesn't necessarily mean everybody gets the same thing. We need to be focusing on what specific needs are of particular populations. The challenge is that the people who miss out are often the people who need it most. And this might not be news to anyone here, given that the group that are joining today and the work that you're all doing. But I think it's an important message that often health services are designed or adapted so that they're supporting those who do already or can already access care. And I like this publication that was in 2021 that talks about that physical health promotion or physical activity promotion is actually perpetuating this gap in access to care, because it's generally the people who can access it are the ones that grabbing it and utilizing it, whereas those who face extra challenges are the ones that continue to miss out. So who is that group that misses out? Well, this will be obviously no surprise to a lot of people here, but people experiencing a lot of different social challenges, people living with disabilities, and of course, trauma-exposed populations. And of course, we know it's compounded by intersectionality. So when a lot of these factors overlap and intertwine, it exacerbates these inequities. Okay, so equally well talks about the various factors that contribute to poor health. And I think these are all the immediate things that come to mind, things like lifestyle, modifiable lifestyle behaviors, including, lifestyle choices, smoking, food insecurity. But what it really, I think quite importantly does is considers these social determinants that contribute to someone's health and well-being. And often in healthcare, these aren't looked at as much. So we need to be considering things like equity to care, low incomes, poverty, housing, these sorts of social factors that have tangible impacts in how they impact or influence someone's access to care. So this led me to think, what can I do around these social determinants as well as these modifiable lifestyle behaviors as an exercise physiologist in my past life and as a researcher now to improve access and equity of care? Well, I thought of two main things I could try and do is use what I learned from clinical practice to adapt programs for populations in need. And the second thing is to build capacity of existing workforces to support better and more integrated care. So my whole talk today is really centered around these two things, which brings me to my research objectives. So all up, I kind of look at my research as physical activity for health equity. And these are the two major arms. To explain them in a little bit more detail, I will go into start talking about improving access to populations in need. So what that looks like in terms of research methodology is I do a lot of work around co-design or experience-based co-design. And that's really trying to understand, by working with people with lived experience, what should services look like? There's a big focus on implementation science. So I really like research where I can see a tangible and real world impact. And I think that's what I love so much about translational and implementational research, is that it really does go into services and communities and evaluate those things as they happen. And so I do a lot of different projects with different health services and communities to try and evaluate and support quality improvement. And in terms of quality improvement, really that's asking the questions, could it be better and how? With the workforce capacity, the type of research I'm doing here is sort of survey-based research. So how bad is the problem and what are the needs? Training and education. Okay, so that's training both sides of the workforce, which I'll talk about in a little bit. And then consensus building and gathering expert opinion. So what do the expert thinks on this particular topic? And that's an important question in the absence of research within that space. So it's really important to gather experts' views and lived experience views. So just quickly, what is translational research? It's taking what we know works and making it core practice. The only thing that we really challenge with this sort of work is that there's a huge time lag between when we make a discovery or know that something's important through research until when it actually happens. And there was one write-up here by Morris that actually talks about this implementation or translation gap being up to 17 years. So there's a huge time lag, and I hope through implementation and translational research, we can accelerate this time lag. So I'm very conscious that I'm speaking at the Trauma and Violence Informed Physical Activity group. And so I want to make a conscious effort to really tie the work that I'm doing to the objectives and principles that underlie trauma and violence informed physical activity programs. So Francine's team have been really leading this space, and I really liked this review that kind of distilled into the main principles of trauma and violence informed physical activity. I'm not going to unpack these now. I feel like most of you will be aware of these, but I will use them to relate them to the programs that I have been doing and show you how these programs kind of align with these different principles as I go through them. So some case studies to give you an example of what I've been doing. I want to introduce you to Frank. Okay, so Frank, Sosafina, Phil, and Sarah. So there's 4 people you'll meet today. Let's look at Frank first of all. So Frank is a 50-year-old male. He's a migrant from the Philippines, and English is his second language. Frank is an actual client of mine. Obviously, I've changed his name, and a picture I'll show you of his lower limb is actually his lower limb. Frank is got so many strengths. He speaks 5 different languages. He understands ancient Greek. He's extremely bright, but he does live with a complex mental illness. He was diagnosed at 25 with schizophrenia, and this was before he moved to Australia. And now he's 50 years old, and he lives in a supported housing accommodation, which is 24 hours accommodation in mental health facility. He gained dramatic weight when he started antipsychotics, and he's now obese in the obese category and has a very increased waist circumference. Lifestyle, he has poor lifestyle behaviors. So he's high discretionary food intake, very sedentary, and he's a smoker. He was referred to me about 6 years ago as the exercise physiologist to help manage weight, was the referral reason. Now, I'm going to show you, that's not the graphic image warning, but I'm going to show you a graphic image. So just prepare that. This is his lower limb that was only became apparent to me as the exercise physiologist in the mental health service when he was referred and I was just doing his weight. So I asked him to remove his shoes so he could jump on the scales. And it was only then when we see this blood around the cuff of his jeans, and this was actually on both limbs. And what we realized is that Frank actually had diabetes, but his diabetes was so poorly controlled and not looked at that he was experienced peripheral neuropathy and this peripheral vascular disease. What we know with diabetes is that the next stage from this is generally a lower limb amputation. Okay. So how is this possible when Frank is under 24-hour care? Well, unfortunately, we know that this is not an unusual story. This is a common situation that happens in mental health, where we see what's called diagnostic overshadowing, where people get treated from the neck up, and only their mental illness is the thing that gets managed. As a result, this is leading to a significant life expectancy gap, which many of you may have heard of before. But I think it's a big problem because that it's not spoken about outside of mental health care. And when I talk to family and friends about this, they are baffled. In Australia, we have a life expectancy gap between Indigenous populations of about the same. That gap is reducing, whereas the gap in life expectancy for people with severe mental illnesses is increasing. Importantly, we know that a primary driver of this is modifiable and lifestyle related risk factors like cardiovascular disease and diabetes, as you saw with Frank. I really like this quote by Professor Graham Thornycroft, who spoke about this scandal of premature mortality as if such a disparity in mortality rates was to affect a larger segment of the population with a less stigmatized characteristic, then we would witness an outcry against this socially unacceptable decimation. So the problem here, it's really a human rights issue. And I witnessed this firsthand in the mental health unit when I was working as a clinician. So this is actually the new hospital where I used to work, Prince of Wales Hospital, and this is the general hospital. Whereas the Kylo Centre, which was the psychiatric inpatient unit, is this very old, decrepit building that's falling apart. And it's kind of considered the ugly duckling, where there's not really any services or support that's provided from the main hospital. We remember we used to want to get physios to come down to look at some of our patients' acute injuries, and that they weren't supported to come down even if they wanted to. So it's often the stigma in the service is very much known. Um, and importantly, this has been identified by the UN. It's a human rights issue, and you can see in bold there, physical health is a part of what reform needs to happen in mental health systems. So key role for exercise and physical activity initiatives. So the proof is in the guidelines. This has now been translated into international and in Australia national guidelines that really support this evidence into real world implementation. So we see that come to commentaries like this that say a little less conversation, a little more action. What I'm going to be talking about is movement, and I want to talk about a few key programs. So coming back to Frank, these are some programs I've been very, very privileged to work with and in some cases lead over the past few years. I'm only going to talk to a few of them because I don't have time, and I'd love to talk about some of the Pacifica work that I've been doing. So I'm really going to focus on the Keeping the Body in Mind program, Community in Motion, and the Minds Collective program. But these are some publications from the other programs that I work with. If you are interested, you're very welcome to access those as well. Both of them started as translational research projects or pilot projects that then have been extended and rolled out into routine practice. So keeping the body in mind for Frank. So how does that improve Frank's health and well-being? Well, keeping the body in mind is an integrated lifestyle intervention, and it's in the public sector. So it's free for consumers who access the mental health service. It started as a 2-year cluster controlled pilot study with young people with first episode psychosis. So as soon as they start antipsychotic medications, they were also provided this lifestyle intervention. They compared Bondi versus another hospital at Liverpool, both in the same early psychosis program, but the Bondi Centre or the Bondi program had this keeping the body in mind intervention. And that had an exercise physiologist, an on-site gym, sport programs. The benefits of this is that we found the weight gain that we see so dramatically with antipsychotics was attenuated with the lifestyle intervention combined. So you can actually prevent the weight gain that we see, which was an amazing outcome. And importantly, those outcomes were sustained for those participants at 2 years follow-up. So great results, which we had a very visionary leader at the time who said, those results are fantastic, but you've only done that as a small project with a few participants. How can everyone get this? Well, he invested millions of dollars, and this was then rolled out across our whole district. So this is the southeastern Sydney area. And this program, the Keeping the Body in Mind program, was then duplicated across various hospitals across the southeastern Sydney area. Importantly, we were able to replicate the findings as well. So other sites were able to show that weight gain could be prevented through the combination of lifestyle interventions. So it's not just the one site or pilot Bondi effect, which often was criticized in the initial publications. It's actually something that could see happen across the district, which was fantastic. And the program still continues today. So what makes KBIM trauma and violence informed? Well, it's delivered in a familiar, psychologically safe environment. It's in the mental health service. So these lifestyle clinicians are working alongside the mental health teams. It's run by EPs, dietitians, nurses who are all trained in mental health, so receive some additional training in mental health or undertaking research programs that focus on mental health. They're all extremely person-centered, flexible, and autonomous, so people can have choice and agency in what they choose to do. And they're very individualized. So we have group and individual appointments options, so people can choose what they would like to do and potentially stage themselves into group-based programs if they experience some social anxieties. There's also a big focus on interdisciplinary care and peer work as well. So we had peer workers within our team that really led some of these programs as well. So there's been huge outputs and great impacts from KBIM, but Frank's asking the question, that's all good and well, but what happens when I'm discharged from the public service? So I'm no longer eligible for KBIM, the Keeping My Body and Mind program. What's for me? How can I continue? So this is where we had the idea of trying to take what we learned from Keeping the Body in Mind and move them into community managed organizations. Now, I don't know if you use the same term in Canada or in other places, but we're talking about non-for-profits. And so these are generally psychosocial programs in terms of mental health. They're less clinical focused, but we wondered whether we can take the exercise physiology and lifestyle interventions and move them into these psychosocial programs. So this is something that I've been focusing on in the past 2 years. Just to give you a quick little map of where they sit in the broader health service, non-government organizations really do sit in this intersection between private hospital general practice and private clinics, and there's great overlap and links between them. So it's a well fit setting in theory. So we want to test that out. In terms of why these potential sites are really good, because they already have such a strong emphasis on choice and agency. And what do we know about choice and agency? They're really important for behavior change. Getting people intrinsically motivated has to have choice and agency. Social connection, there's a huge emphasis on group programs already within these non-for-profit mental health services. They do help link with the clinical services as well. So they refer back to community clinical settings or inpatient settings. There's a strong emphasis on trauma-informed care. And so there's recovery-oriented practice, strength-based approaches. These are all very much things that already occur within CMOs. And at least within many of the sites that I work with in Australia, more than half the workforce are peer support workers, so lived experience workers. So there's a big role modeling aspect here as well. And trusted community, so that these are services where people come back to. So in terms of taking what we know, this is the pilot site that we're trialing with. So Flourish Australia is one of Australia's largest community managed organizations. And I was fortunate enough to get the support from their CEO to try and do this work at one of Flourish's sites in Sydney. So we won a small grant that allowed us to test this. So what we're doing is embedding an exercise physiologist into the Flourish site, the community managed organization. And we're also looking at building staff capacity through training, developing training there. We had a few resources thrown at us, which was absolutely fantastic, and a PhD student, Regan, who's been working on this project. And we also had great investment, which I think is really important, from Flourish itself. So they provided $160,000 to supply funding for the exercise physiologist when we were sort of supporting with the research and evaluation. Lots of collaborators involved in this project, and it's been running for about 2 years now. So what did we do in terms of activities? Well, we did lots of experience-based co-design, ongoing feedback, and we've also done some art-based inquiry. And I'm going to show you some of these results quickly now, but just to give you a quick glimpse of the gym and what it looks like. This is in the community managed organization, and we got funding for this equipment to set it up, and the exercise physiologist now runs sessions 3 days a week and group programs as well. So what did our co-design look like? Now I realize I'm speaking to experts in co-design here, but I'm just showing you a glimpse of what we've done. So we've conducted focus groups and interviews, and we did that with a variety of different stakeholders. So staff, consumers, family, and carers. We're analyzing these in line with implementation factors. So we're using existing frameworks like the COMB model and the Consolidated Framework for Implementation Research. So these help us to identify what factors help programs get embedded and sustained within these programs. We're then going to go back with all these proposed outcomes to our stakeholder groups with a smaller subset of them, but still a mix of the different stakeholders and check with them to make sure that that's aligned with what they originally told us. And then ideally, the final product will be a bit of a blueprint for how these services can be implemented in community managed organizations in Australia. A really exciting project that I've never been involved in before. This is an opportunity that came up through some funding for Flourish because they had an art exhibition coming up and they said, would you be interested in doing something around art? So we wanted to extend the co-design through some art-based inquiry where we asked participants simply, what does movement mean to you? And they did a painting, they drew a picture, they created a sculpture, whatever method they chose to do. And we're going to write this up as a separate evaluation to understand what movement means to people who access these services. And there were some absolutely beautiful artifacts that came from this, as well as some quotes that support it. And this is the kind of qualitative research that we'll be analysing for this particular paper. In terms of sessions, we had really good engagement. So huge a number of referrals. I think I get really excited by referral numbers because that doesn't just talk to program attendance. It talks to how engaged the mental health services are in terms of referring people to the program. So I actually think that's a really important indicator. Of them, 70% of people attended more than one session, so that they at least came and they wanted to come back. We've had 811 total sessions, occasions of movement, we call them, and average sessions around 4.5 a day. And in terms of capacity building, we've got student placements and lots of hours. Importantly, the program's really acceptable as well. I won't go into the fine details of that, but people were really enjoying the program. So in terms of community in motion, similar to KBIM, it's in a safe space. It's run by an AEP, choice and agency. It's with an MDT as well, but there's a big peer workforce influence. It's a free service like KBIM, so that's that barrier around financial hardship and discrimination we're mitigating. And it's a predictable and safe environment, so it's providing people with a bit of comfort and psychological safety when they attend. Frank wants to know what we can do that's something that's a bit more fun and engaging and social. So this is where Minds Collective comes in. So this is a free community-based football program for adults with mental illness. It's a partnership between our local council here in Sydney, Collective Leisure, who's a social enterprise in Sydney focused on equitable physical activity initiatives, and then my research team as well at UTS. We get referrals from mental health services, and we've been supported by Thread Together, who's a non-for-profit here that provide free equipment and clothes for particular groups. And they provided football boots for all of our players, which is fantastic. The good news with this program is that it started as a 3-month pilot and it's now been funded for 3 years, which is fantastic. So people can go to a free football program on a Friday delivered by mental health first aid trained soccer coaches and participate in this group. There's an hour of football, which has been pushed out to an hour and a half because people love it so much. And then an hour of social discussion, snacks are provided. People talk about all sorts of things and making good connections through that time as well. So I've spoken a little bit about the program, so I won't go into this because I'd love to talk about the Pacifica stuff before we finish. But the program's been very well received. Lots of services have referred, and we're going to be evaluating this as well. So in the past 18 months, we've had 82 participants. Schizophrenia, spectrum disorders are the primary diagnoses of people that are coming through. 16 referral organizations, both from the public sector and from CMOs. And 51% of participants attended more than 70%. So good retention. 2 mental health first aid trained coaches and 6 student placements. Some of the quotes here. Talking to people about other mental health issues makes you feel good that there's other people going through something. So the real peer support nature of this is coming through. For some people, it's the thing that makes them most excited about the week. And I've started to make good friends. So a lot of really reinforcing things there around social support. So how does it relate to trauma and violence informed physical activity? Well, it's co-designed, so giving people influence on how the program was designed. Strength-based and connection building, so it's really accessible in terms of providing people with the equipment that might prevent them from engaging in these programs. Choice and agency, so people can choose to participate. Sometimes we have people that come out and just sit on the sidelines. We don't necessarily nag or force them to participate. We do initially encourage them, but if they're not feeling it that day, more than okay. They can choose to watch on the sidelines. And we train the coaches, as I mentioned, in mental health first aid. And we also encourage support workers and family members to actually join in on the football as well. So we're getting good attendance. So Sosafina, a 50-year-old woman, second generation Samoan living in Western Sydney. She's part-time retail. She's married and she has 3 kids. Um, she's overweight in the obese category, and she has family history of cardiovascular and metabolic issues. Um, she's also quite sedentary and she's quite stressed. Her sleep is quite poor because she's living with such a big household and has so many commitments in terms of her family and work. Strong cultural ties. And lifestyle wise, because it's such a high stress and in Western Sydney, we've got, I guess it's a primary example of the social gradient where on every corner of every street almost, that's an exaggeration, but there's a lot of fast food options in Western Sydney. It's generally a lower income area. And as a result, people very readily access these sort of fast food chains. But Sosafina wants to get fitter, have more energy, and set a good example for kids. So what can I do through my research here? Just to give you a bit of context, Western Sydney has one of the largest diasporas of Pacifica people within Australia or even outside the Pacific Islands. So when we're talking about Pacifica, we're talking about Samoan, Tongan, Fijian, we're talking about Cook Islands, a number of those different islands surround the Polynesia, Melanesia, and Micronesia. Yeah, so 1.6% of the Australian population, but absolutely growing. And Western Sydney has one of the highest populations. Unfortunately, like in the mental illness space, we do see high comorbidities and big disparities in health between Pacifica and non-Pacific groups, with a 14 age year younger ICU hospital admissions. So with David Burns and Yvonne Peacock, who's a Samoan Samoan pediatrician nurse at Western Sydney Local Health District, we got together and tried to take what we learned from the mental health space into the Pacifica community in Western Sydney, which led us to Pacifica Moving, which is where we use co-design and then a pilot program and evaluation to roll out something similar. The steps in co-design that we did here was to engage first, gather, understand, and improve. And I'll run through how that looks. But importantly, we used a culturally relevant framework to understand this. And this was called the Fonafale model of health. And this is where things like spirituality, physical, mental, social, and as well as culture and family play a big role in the health of Pacifica communities. We developed an advisory group with key international academics and researchers and clinicians. Really lucky to have Soale, who was a descendant of a Tongan prince. He's a child and adolescent psychiatrist in Auckland, New Zealand, and was happy to be part of this. So we had a really good group who identified that, well, Pacifica mums are the ones that miss out the most. For men, footy is a big part of the life. For kids, there's programs in schools, but mums are often left at home without any physical health care or social sport opportunities. So this is where we thought a primary population to work with. And we designed a 12-week pilot study through Talanoa, which is open community dialogues. It's kind of like a focus group, but it's done in a Pacifica-led manner, and it's in a low scientific or research context. So we didn't record these sessions. Food and snacks are provided, and it was sort of guided through Pacifica cultural principles. Some key quotes from Talanoa. In Pacifica culture, if I go to the gym, it would be considered selfish. In Pacifica, if I do something for me, the community comes with me, which is a beautiful sentiment. I feel like it's something we need more in Western cultures. But as a result, it is a barrier for the women to participate because just getting a gym membership, leaving their kids with a childminder is not really reality for them. Culture is a barrier. You have to wear big, long shirts so that people can't see your bum. And I sweat a lot, but I have to cover up so much. I don't go to some church things because of dress expectations. And then the final quote, which I think really resonated, was slapping Pacifica on the front of it doesn't make it relevant. So having community leadership was really important there as well. So what does the program look like? Again, it was initially 3 months through a social impact grant. It's now been going for 18 months, and we're evaluating a qualitative study that maps all these aspects of the Fonafale model to the research outcomes. Um, and we're just keep growing. On Saturday, I went to a program that was led by Yvonne in Western Sydney, and it was a cancer awareness day, and it was a volleyball day, and we had 5 different volleyball teams come and participate. There were over 30 Pacifica women and their families that came and joined. So it's gone from absolute strength to strength. How is this program trauma and violence informed? It lends on principles that I've mentioned, but I think unique to this one is that it's very much Pacifica led. So it's absolutely driven by the community. I actually don't go to any of the programs as a white, or as they say, a Palangi male. So I don't actually see these programs happening, but I hear and speak to Yvonne and we talk about it very often. So it's women only, safe, psychologically safe spaces and Pacifica led. It's culturally safe and responsive. So they start every session with a prayer. So religion is really important within this community. And so they start with a prayer and they end with a talanoa and a discussion. And some of the interventions are not conventional exercise sessions. There's been healing hula, which is a form of sort of Pacifica dance, which is adapted to be culturally and trauma informed. So it's supporting a lot of women. And I think just really to relate to this, some of the interviews we did post-program, I remember one of the ladies didn't specifically say, but she said, being here at this program is particularly important for me right now because of what's happening at home. And I think even more important that it's a women-only space. So I know from reports from the community that domestic violence is a big issue within the Pacifica community in Australia. And I think this program has provided, incidentally, a bit of a safe haven for a lot of women who could come and access it as a form of social support. So really important that it's women only program. I'm very conscious of time, so I'm going to quickly rush through these, and if in the discussion we can come back to Phil and Sarah maybe and talk about it a little bit more. But the principle of Phil and Sarah is Phil is about building the cross-stream capacity building. So getting mental health professionals upskilled in providing physical health support for consumers and getting the exercise professional workforce more mental health informed. And that includes trauma informed. So some of the work we've been doing with the Phils of the world, who say might be a clinical psychologist, is designing programs, understanding what their needs are. So doing surveys with the staff to look at their confidence, skills, and knowledge. And I won't rush through the results because we can talk about them if it comes up in the discussion. But with Tatiana Rock, Sam Mangja, we've been doing also another consensus statement that looked at identifying education topics to teach the Phils of the world, the mental health clinicians, about what's important to know from physical healthcare and lifestyle interventions. So this was recently published this month in Critical Public Healthcare Journal. And we also did a consensus Delphi approach with this. And these were the key topics that came out. So in terms of modifiable cardiometabolic screening, lifestyle intervention, medication optimization, behavior change strategies, integrated care, addressing barriers, minimizing barriers for consumers. So barriers for implementation, sorry, and then barriers for consumers and clinical research. So I'll provide the link to that paper if people want to look at. The really cool thing about this work is that it's already being integrated into training programs. So Tatiana and Sam lead the various different workshops and degrees and credentials that you can do here that look at lifestyle medicine or lifestyle psychiatry, where these education topics have been adapted and included. For the exercise professionals, we have a consensus project as well, which Grace was involved in, and this was to design the consensus statement, the ESSA consensus statement on the role of exercise physiologists in mental health. We did a very complex and a detailed Delphi approach with this one as well. Hopefully this is going to be live soon. We've got it under review at a great journal. And so I'm really excited to share the results of this project. But here we had a slightly bigger Delphi with 46 participants, including lived experience experts, mental health clinician and exercise physiologist. And we identified a number of best practice principles. Now, I know the team in Canada are doing amazing work in terms of developing online training modules around trauma and violence-informed physical activity. I'm hoping that the principles here absolutely overlap with that, and we can use this to support in training Australian exercise professionals through these principles as well. So you can see some of the main principles that came out there. And we try and align that with all stages of an exercise physiologist intervention. So everything from referral and intake to discharge and follow-up. So this will be all hopefully more detailed in the paper. My hope through this cross-stream capacity building is that the exercise physiologist and the psychologist can swap weapons, and the exercise physiologist can be more effective in providing psychosocial support, i.e. the tissue box, and the psychologist or the mental health professional can be more effective in promoting physical activity and physical health care. So just to wrap up, I want to acknowledge my team at UTS, my team through Community in Motion, my team through industry with Pacifica Moving, my Keeping the Body in Mind colleagues, national collaborators in research, and the Nexus team at UNSW. And most importantly, all the people who access the service and have been benefiting from the program, who provide ongoing input and support as to how the programs are designed and shaped, and open to questions and answers.
Amazing. Thank you so much for that, Oscar. I know there's been so much work that's gone into each of those projects. Well, lots of claps coming through. We could have listened to each of those projects, I'm sure, for an hour themselves. We are we're going to have time for one question before we then jump into our breakout rooms, and then we can have some more detailed discussion. There is a comment in the chat just thanking you for your talk, Oscar, but saying, asking if the slides will be available. We have recorded this session and our YouTube channel is up there on the slide, so you will be able to access those. We do have a question from Maddie Oscar. She said, thanks, Oscar. What an engaging talk. I found the KBAM study super fascinating and have a couple of follow-up questions. Were there any outcomes second to weight management, e.g., mental, social health outcomes? And secondly, were there any other factors that you controlled for in the analysis, e.g., medication type, social or familiar support?
Thank you. Thanks, Maddie. So in terms of other outcomes, we did measure as part of like the routine care, things like dietary intake. So there was a 24-hour diet recall, as well as physical activity levels and fitness. But because it was part of routine care, things like fitness and strength assessments that the exercise physiologist was doing, the data got a little bit messy with pre and post outcomes because it was routine care. We weren't actually able to report too many of those, but we did see in terms of the physical activity levels and nutrition quality, reduced sedentary behavior, increased physical activity levels, and improved nutritionary intake. We didn't capture any mental health or psychosocial outcomes in this because I guess the study itself was in conjunction with the usual mental health treatment. And so they were capturing mental health specific data as part of that routine care as well. And we were very mindful of overburdening participants with too many surveys and sort of various different data captures happening at the same time. The reason I only report on the cardiometabolic outcomes is because that was, I guess, the primary um, incentive of the program to manage the cardiometabolic risks. And that's really what, I guess, cemented ongoing funding for this program. But absolutely, anecdotally, we saw huge psychosocial benefits. We did have a qualitative study on the Keeping the Body in Mind program that talks about people's experiences in the program, which is published and accessible. So you can look at some of those psychosocial impacts through the qualitative work.
Perfect. Thank you, Oscar. I'm just going to hand over to Maddie quickly, who's just going to mention an event that we have coming up before we jump into our breakout rooms.
All right, so just briefly, we have our social media up there. Like Grace was mentioning at the beginning, we're kind of coming to the end of our public health grants, so looking to wrap up some outputs and hopefully have some new publications and other things coming. So keep an eye on those spaces. And then on June 3rd, for the Ottawa folks or nearby, we're going to be doing an in-person event where we're going to be sharing some of the more arts-based and creative knowledge mobilization work that we've been doing over the last few years, all about just kind of equity and movement, who gets to move. So, yeah, keep an eye out for updates on that as well. So that's June 3rd. I think we've locked in a date. All right, back to you, Grace.